Hi Ninja Nerds, in this video today we're going to be talking about acute kidney injury. So if you like this video, make sure you give it a thumbs up. Leave me a comment down below, I really appreciate it. And don't forget to subscribe here to Ninja Nerd Nursing. Go over and then check out ninjanerd.org. That's where all of our notes and illustrations are for you guys to utilize and use with our lectures here up on YouTube. With acute kidney injury, also known as AKI, we're going to be talking about a sudden change in our kidneys' function. So, when we talk about our kidneys are these amazing organs that allow us to remove excess fluid, get rid of waste, products, electrolytes, things that our body doesn't need anymore, get rid of those, keep a nice balance of everything else that's in there, and put those back into our body. When our kidneys aren't working properly, we start to see issues. We start to see buildup in electrolytes and waste that we don't want within our body, fluid in places that maybe we don't want it. And because of that, we could have issues down the line of our kidneys functioning from acute to chronic kidney disease. So with acute kidney injury, or AKI, when we say the word acute, we want to start thinking about the word sudden. And when we think of the word sudden, we want to start saying to ourselves, an AKI is a sudden decrease in kidney function. And this approximately sudden means that it's around 48 hours of this occurring. So we have somebody that within 48 hours, all of a sudden has a change or an alteration in their kidney function. Now there is potentially an injury to this organ where it's not going to proper the way it needs to. And when we look at the kidney, we're not only going to be focusing on the kidney in this video, we're also going to be focusing on the structures before and after it. So if we look here, we have our heart, right, with our abdominal aorta, our renal artery. We have our kidney with all the filtration that occurs in there. And then we eventually have filtrate that comes out of our nephrons, right? Eventually becomes urine down through our ureters to our bladder, through our urethra, and then eventually we have urine, right? And when we look here, when we're talking about acute kidney injury, we can break it into three different types of injuries. We can start to think pre-renal, that something is occurring before the kidney, intrarenal, something is occurring in the kidney, or post, after the kidney. So to start, we're going to be talking about first pre-renal. And when we look at pre-renal, we're focusing mainly on the heart and the vessels to the heart, right? And with pre-renal, we want to think about what goes into the kidney. I always think blood, blood's flowing into the kidney. That's eventually how we can filter it. So when we start to think that way, it's easier to remember that pre-renal has to do with a decrease in perfusion to the kidney, or a decreased blood flow or volume to the kidney that's going to lead to a decrease in perfusion. And when we think in this aspect, we can then start to think about how could we have a decrease in blood flow to the kidney? What are some things that would cause our body to not want to put blood to the kidney or have an issue of getting blood to the kidney? So one of those is easy to think is, do we have enough blood, right? The word for that is what? So hypovolemia. If we have low counts of fluid, right, of blood within our heart, it's not going to properly get pumped to the kidney, right? And that's going to cause a decrease in the perfusion. So what are some things that would cause us to have hypovolemia? One of them could be we're having fluid that should be within our vessels. It's not. It's somewhere else. It's in our feet. It's around our lungs. It's in our hands, right? We call that edema. But the process of that occurring and that volemia, necessarily, we're not hypovolemic within our body, but we're hypovolemic within our cardiovascular system. Something in here is not correct. What we call that, or what that process is what we say as third spacing. Meaning within our cardiovascular system, we don't have the proper amount of volume to be able to perfuse, right? So think of people with CHF, right? They're going to be third spacing a lot of fluid. Think of pancreatitis, with people who have leaky vessels, so that fluid is leaking out. People that are having issues with their liver, so we don't have the proper amount of albumin in our blood being created. Therefore, vessels are going to be leaking out fluid because water likes to follow albumin. And we can also think simply as, what makes a patient dehydrated? What makes a patient hypovolemic? Are they having nausea and vomiting, diarrhea? Are they diaphoretic and sweating a lot? Are they having overuse of diuretics and they're just urinating a lot? All of that would create our patient to be hypovolemic, third spacing, right? With that hypovolemia, we can also think about patients that just don't have enough blood, right? They're losing blood. So that word for that is if we have opening or burst of blood somewhere else that it shouldn't be, and we're losing a lot of our blood very quickly, that's a hemorrhage. So if a patient's got some type of GI bleed, if they have some type of wound that's profusely bleeding, they could be hemorrhaging, and we're losing our blood volume. From there, we can also think about pre-renal. We thought about the fluid that's getting to it, but what about if we're having issues pumping, or if we're having some type of block along this aorta or along the renal artery? So you want to think about a blockage. And what could be causing a blockage to our kidney that is going to cause a decrease in perfusion? Especially right here along that renal artery, right? That vessel that's going to be able to bring blood to our kidney. If it's got some sort of plaque or thrombus that's occluding or blocking part or all of that vessel, then we're going to have a decrease in perfusion. And the last thing we need to talk about then is what is going on with the patient when we do have enough volume, but we don't have a blockage. Instead, we have some sort of systemic dilation, right? Vasodilation occurring all over, like septic shock, some type of liver failure. And what's going to happen is our vessels are going to dilate really big. It's going to cause that hypovolemic issue, right? And when we are hypotensive issue, and when we have that hypotension, what happens within our body when we have hypotension, right? The body likes to protect what two organs? It likes to protect the brain and the heart when we're going through hypotension. So what organ doesn't get blood perfusion as often as it should? The kidneys. So the kidneys start to shut down. So we want to look at this and think hypotension or systemic dilation. Okay, and now we're going to go into intrarenal. When we look at intrarenal, we're going to be talking about issues within the kidney. Okay, so for the most part, for this, it can be caused by pre-renal, causing an intrarenal, meaning we've had a lot of issues with the blood getting to the kidney, so therefore we have ischemic damage to this area. It could be that there was some type of medication that caused damage to the kidney that was nephrotoxic. Could be that the patient had some type of infection. And when we look at all of these, it basically has to do with a decrease in the ability or a damage to this area. So we're looking at things like, when we say damage, and when we think of damage, we can think of things like inflammation to the area, necrosis to the area, right? So with intrarenal, we want to think about the damage that could be occurring within here, okay? So because of all of these, and there's many other issues, I just want you to understand that intrarenal has to do with damage or an impaired in function to the kidney because of inflammation, necrosis, or damage to the kidney itself. And then we can go on to postrenal. With postrenal, what we're looking at here is everything that has to do with after the kidney. So we have our two ureters, our bladder, and our urethra. So when we're thinking about this, now we've gone through what the whole purpose of the kidney is to take blood, filter out the junk, and then eventually make a filtrate that becomes urine, and we get rid of the waste, right? So with postrenal, you're more so focused on the urine aspects of the kidney function. So with postrenal, we're focusing on an area of the urethra, ureters, and the bladder. And essentially, there is going to be some sort of blockage that is along this pathway or an occlusion to the area. So when we look at this, very simple to think, what would be an issue with our ureters that are going to be able to take urine out of our kidney, right? Take that waste away. What would it be happening to them if there was some type of blockage or occlusion? What would be one of the causes? Renal calculus, right? They have a renal calculi. They have a kidney stone that's blocking the ability for that to drain. Could be that there was some sort of trauma or damage, right? Maybe there was something happened, they were in some type of accident, there was a tumor or a cancer that was growing and it's occluding this and blocking this. And when we think about the renal calculus, it could also be down here in the bladder, could even gotten stuck in urethra depending on what type it is, how big the urethra is, issues like that. With the tumor and trauma, we can also think about lower down here in the bladder and into the urethra. When we think about tumor, we can think about benign prostatic hyperplasia, prostate that's enlarged, that's squeezing off and closing our urethra. We could think about trauma to the area. One of the things we do often as a nurse, and we learn a lot in nursing school, is how to put in a catheter, right? So if a patient is either self-cathing or we're cathing them numerous times over and over, there could be damage or trauma to the urethra, causing swelling, causing a blockage. And then the last thing we could think about is with a patient who has an issue, not necessarily with a blockage or occlusion per se, like the tumor or the trauma or the calculus, but they're having an issue with the muscles or neurogenically. So maybe there's an issue with the muscle being able to contract around the bladder. Maybe there's an issue with the sphincters not being able to open and close. So when we think about those, back to the spinal cord, we can think about patients that are having neurodeficits. And when we look at all of these issues, right, we're thinking about how these patients with neurodeficits maybe can't empty the bladder, right, or there's a tumor or some type of trauma that's not letting urine come out. Then there could be a blockage or a buildup of urine within the bladder, backflowing to the kidney. Now the kidney's having an issue, and then we can have an infection brew in here or anything else. And then all of a sudden now we're having all these other issues within the kidneys, right? And when we look at pre, intra, and post-renal, they're broken into 3 different areas. And for me, it's easy to think of an analogy kind of like an IV pump setup. So for me, if you think about pre-renal being your whole issue up here with the bag and the fluid before the pump, you can start thinking of what are the issues that the pump, the kidneys, are going to have if something before it's not working. Well, if there's not enough fluid in the bag, this pump's going to beep. If there's an issue with a clamp before the pump, it's going to beep. If there's an issue where it's not flowing properly, right, it's going to beep. Within the pump, you think of that as like your circuit or your hardware. If there's an issue with the pump, the battery's low, right? There's someone, banged it on transport and now it's not working properly. There was damage to the motherboard in there. All of that could cause issues with our kidney functioning properly, right? And then post-renal would have to do with anything occluding or blocking as well, right? What are some issues with our patient here? There's an occlusion at the end of the catheter. We didn't open our clamp after we primed and set the tubing, right? We could have all these other problems too. And for me, it just makes it a little simpler to think, okay, that's what pre, intra, and post-renal are. If there's some type of blockage, an issue with the hardware, or some type of blockage after, is there enough fluid in my IV bag to get me through my shift? If not, I'm going to have to change it, or the pump's going to be angry, right? And then when we look at all these as a whole, there's a lot of different signs and symptoms that the patients exhibit in order for us to start to think they may be in an acute kidney injury. So let's talk about those now. All right, engineers, now that we talked about the different types of AKI, let's quickly talk about the different phases of AKI. So regardless of the type of AKI that the patient has, there is a couple different phases that the patient goes through, very similar to each other. They're not expressly the same between each patient, but they are very similar. And this is an area that sometimes the NCLEX likes to touch on or ask questions about. So let's use the blue marker here. And we're just going to talk quickly about onset. So onset is roughly around that hours to days mark, right? We said about 48 hours. So there's roughly hours to days for onset. And with patients like this, there's typically not many symptoms. They could be asymptomatic. They don't really notice it. Or it could be that the symptoms are so mild that they don't really pick up on them until they get a little more severe. So there could be something like decreased urine output, decreased GFR, right? Not that the patient's going to be at home checking that, but if there's a decrease in the urine output, there's most likely a decrease in the filtration at the kidney. And let's think about that again, back to what we just talked about in the pathophysiology. There could be a decrease in the perfusion, right? There could be an issue within the kidney that's causing a decrease in the glomerular filtration rate. So because of that, we could be seeing mild symptoms, but nothing too much that the patient notices. And we go over to the oliguric stage. Oliguric stage has roughly around 1 to 3 weeks of duration. And this is where the patient's going to start experience some issues, right, or some symptoms that we're looking for. What are those symptoms? Well, decreased urine output is going to be more significant, to the point where this patient might be oliguric or anuric, right? They're either not making a lot of urine or they're not making any urine at all. So if we think about if there's a decrease in urine output, we know that that causes a decrease in the GFR. What are some things that we're going to be looking at with this patient? They're going to be having increases in what? Their BUN and creatinine is going to be increased, right? They're going to have changes in their electrolytes. When we say changes in those electrolytes, one of those might be this. We get an EKG on this patient and we see that they have a peaked T wave, which means what? Hyperkalemia. This patient could have issues with fluid, so they might have some edema. They might also be complaining of being fatigued or tired. And when we start to look at this patient, we're going to start thinking, okay, you have tiredness, you have some edema. They may complain of other things like altered mental status, a little bit, getting confused. They might be having some muscle cramps, right? And the biggest concern for us is that decrease in that urine output, and for how long has that been going on? Some patients might not be able to tell us, right? We have a patient that's maybe nonverbal. They are incontinent of urine. They don't really know. And then for like 3 days, they haven't been making urine, but no one said anything or the family didn't notice. And now we're looking at, something's going on with this patient. So we've identified then at this point, this patient is having some type of kidney injury, and they eventually progress into the diuretic phase, or this is the phase that I think about as treatment, right? We're going to be giving them diuretics. So this can roughly last around 2 weeks. Could be longer, again, depends on the patient. We're patient specific with this treatment, okay? And with these patients, they're going to have, again, changes within their functions, right? Before they were having decreased urine output, now they're going to have increase, because we're putting this patient on those diuretics. So now they might be peeing a lot. Because they are urinating a lot, they may have, again, changes in their electrolytes. Where here, it was more so increased in the oliguric stage because they're not eliminating that waste as much as they want to. In the diuretic phase, now we're having the other issue where we're urinating so much with that dilute urine, we might actually have a decrease in these electrolytes. So that decrease in those electrolytes, but that increase in that urine output, we're going to have what other issues? They could be fatigued, they still could be having issues, but because we are increasing that urine output and we have that dilute urine, what is something else that might be occurring? That edema is going down. Hopefully they have a decrease in that edema. If they had some pulmonary edema, maybe now they're starting to notice, hey, I can breathe a little better because we're pulling that fluid off. And then we can go eventually into the recovery phase. And when we talk about the recovery phase of a patient, this can go from months to years. Remember, we talked about patients that have an AKI having hopefully reversible damage, but that doesn't mean that damage is reversed very quickly. It can take months to years. But at this point, this patient is hopefully getting a normal urine output. They're getting baseline BUN creatinine, meaning back to their normal self, right? And they're going to have baseline GFR, right? So it's allowing us to see that this patient is in recovery. There may be fluctuations throughout their care, right? But what we're looking at is that it's all going back to hopefully their baseline prior to whatever injury occurred to them. And when we look at all of these phases, and when we look at these patients, it's those main causes or those main symptoms that are causing very similar signs and symptoms or similar manifestations. It's going to be that decrease in the urine output. It's going to be the fatigue, the edema. When we look at all that, along with whatever else is going on with that patient, like we said before, are they having some type of infection? Are they septic? Are they having some vomiting and diarrhea? Do they have a hemorrhage somewhere? Do they have a kidney stone? Do they have a tumor somewhere blocking? All of that is eventually going to be figured out, but this is the general route that they go with these very similar symptoms, because it really depends on what the cause was. So when we have these patients present with these symptoms, we're going to come in and we're going to say, okay, this patient I think has an AKI, has some type of injury to the kidney. What diagnostics are we going to run? All right, engineers, we're finally at the part here where we're going to just diagnose, hopefully get a diagnostics on our patient, figure out what the issue is for them, and then treat them. So when we have a patient that is coming in with complaints of decreased urine output or any other issue that we think, okay, something's going on with the kidney, we're going to be checking the blood, we'll be checking the urine, and then probably get a picture, right? And when we check the blood, we talked about it before, we're going to be looking at what? If we're concerned for the kidneys, we're going to be thinking BUN and creatinine. Specifically, it's going to be increased. With the increase in BUN and creatinine, we said before, changes in the electrolytes. Specifically, hypernatremia, hyperkalemia, right? All those increases. And then we're also going to be looking at their urine. When we look at their urine, we're going to be seeing the urinalysis. It's going to have what? It could have blood. Hematuria could be positive for protein. They could have an increase in urine-specific gravity. Yeah. So this patient's got some increases in their BUN and creatinine. They got lots of changes in their electrolytes. They're having issues with their urine. And when we think about the electrolytes, they eventually go and get an EKG, right? And we see a peaked T wave, right? Causing concern for hyperkalemia. And then we also get eventually diagnostics. What are some diagnostics these patients could get? They could get an x-ray, right? It'll be able to tell us if there's anything else going on. If they're just complaining of back pain, maybe we're thinking it's musculoskeletal or bone, so we'll get an x-ray and then we see a nice little speck we want to investigate, maybe with a CAT scan that's going to tell us, actually, you have a kidney stone. There could also be ultrasounds that we do to look for any other structures that could be occluding or blocking the area. And then after all these diagnostics are done, if there's more further investigation, this patient could go for a renal biopsy. But when we look at the treatment and the nursing interventions for this patient, we want to remember that it's going to be patient specific. Meaning we're going to be treating their underlying cause. Once we treat their underlying cause, whether it's an issue with volume and they need more fluid, whether they need diuretics, whether they have a blockage that we need to remove, or they have an infection we need to give antibiotics for, as we treat the underlying cause, it's very similar care, basic nursing care after that. So let's think about it. We have a patient who is maybe on some type of medication, they're having issues with their electrolytes, we're making them go from not urinating to urinating a lot. So the basic things we want to check are their vital signs, keeping an eye on their EKG and telemetry, and then their blood work and their urine or urinalysis. With the urine, we also want to think about their INOs, making sure that we are keeping track of this patient's INOs, their daily weights, keeping an eye on what's going on with their edema, and then also their diet, giving them a high caloric, low protein type of diet, right? Because we want to make sure that they are keeping all the fluid that they have in the areas that they need to, and then getting rid of anything that was excess. And then anything from here on out is just going to be basic monitoring as well, right? We're going to be listening to the lung sounds, making sure there's no buildup. We're going to make sure that their edema is going away and making sure that they're just having a correct return to kidney function. We're looking at all of these because we want to make sure that when we're diuresing this patient, that they are able to get the correct vital signs, right? They're not dropping too low and they're becoming hypotensive from all those diuretics. The EKG is not showing some other issue where now we fixed the potassium issue, but now we gave them a calcium issue, right? And then the blood work and the urine is going to be able to tell us if we're doing those things, if we're correcting them appropriately. Then we also want to keep an eye on all these patients because they do have an acute kidney injury. They could also have an issue with nephrotoxic drugs or even drug doses in general. Thinking about that decrease or that inability for the kidney to work properly, there could be issues with the metabolism of different types of medications. So we want to keep an eye on their kidneys as well. And then overall, we just want to facilitate them emotionally and support them because this could be very traumatic if the kidney function isn't returning, and now we have to think of alternatives like dialysis. And that's it, Ninja Nerds. That is the entire lecture on acute kidney injury, also known as AKI. I hope you learned something from it. If you did, leave a comment down below. And if you thought of an analogy for pre, intra, and post-renal? Leave it down below. I'd really like to see it, read it, and I do appreciate it. And as always, until next time.